Hello everyone, this is Dr. Sanket Pisat, and today we are discussing yet another question put forth by one of our consultants in the endogyne training group, and this is about prolonged catheterization for a difficult bladder dissection during laparoscopic hysterectomy. Before we start off, again let me invite those of you who have not yet joined to join our discussion group by visiting the website www.endogynetraining.com. That's ENDOGYNE training.com, where you will be able to find the link to join the broadcast group and other groups where you can take part in such daily or frequent discussions that keep happening as regards daily life problems in gynae endoscopy. So let us begin with the question at hand. And you can see that the question that has been asked is that TLH was done, laparoscopic hysterectomy, for a patient with previous to cesarean sections where the bladder was densely adherent. Now the question is, prophylactically, can prolonged catheterization for about 8 to 10 days prevent vesicovaginal fistula in such a case? And does it really matter if whether prolonged catheterization is done, or will it not help at all? And this was the poll that we had put out to our gynecologists, and you can see that about 2/3 of them have commented that it won't help, and the remaining 1/3 of them have commented that it will help. So you can see that there is a significant difference of opinion in this matter. Among some other comments that we received, right, so some people have said and advised that they would do cystoscopy after TLH to confirm the thermal spread over the bladder. Then again, some people have advised catheterization for 1 week, then to remove the catheter, do PS examination, and if it is normal, then do catheterization again for 1 week and then remove. And also the fact that VVF will probably be diagnosed within 14 days, but not sure. Then again, somebody else has opined that it depends on the type of injury. Thermal injuries, it won't heal. Minor lacerations may heal. And again, somebody has said that cystoscopy should definitely be done in such highly adherent bladders. Another set of opinions we see over here is that while people say that it is cystoscopy, it is fine. Means cystoscopy should be done is what some people have said, and also somebody has put forth the idea that the decision will depend on how the dissection was carried out, because not this person has voted not useful, because the idea of long time catheterization is to keep the bladder for stretching, which worked is what the doctor says for obstructed labor, and it won't work in this case. And again here somebody else has said that cystoscopy was normal, but there is no way that how whether we will prevent the development of fistula, and they did send the patient home on prolonged catheterization. So the point is that whether we are not really sure of whether such an act of keeping the catheter in for a long time as a prophylactic measure is really useful or not. So let's try and analyze this whole thing one thing at a time to see exactly what should be done. Again, this is my personal opinion. You can have a difference in opinion, and if you do, I would request you to please share your views in the comment section on the YouTube video, or in one of the groups if you're already there on the endogyne training broadcast group. So let's see what we are talking about here. We are talking about a query injury to the bladder, and we are not sure whether an injury has occurred or not. Now here, when we talk about injury, let's get one thing straight, that we are talking about two different types of injuries over here during hysterectomy. One is a bladder injury and one is the ureter injury. Now as such, these are completely different types of injuries and their management is completely different. But when we talk about bladder dissection in previous to LSCS, the common type of injury that can happen is actually a bladder injury. For a patient with previous to LSCS, whenever you are operating, to have a ureter injury really doesn't make too much sense, because the ureter does not come anywhere in the picture when you are dissecting the bladder for multiple previous cesarean sections. The ureter does come into the picture when you are doing dissection for deep infiltrating endometriosis, when you are doing dissection for large adnexal masses, and so on. So for previous to LSCS, there is really no question about ureteric injury per se. Let's try to take a look at a little bit of this anatomy before we actually go forward in this matter. Okay, so if we look at the anatomy of the pelvis, what we find here is that the urinary bladder and the uterus, obviously, as we all know, they are related to each other. But while performing hysterectomy, what you are going to be looking at, or what you could probably end up damaging, is this area. So we are looking at a problem over here in this area where the two could be adherent to each other. While doing a hysterectomy, the ureteric orifice lies pretty far away from the area of dissection where you would separate the bladder and the uterus. Add to that the cranial traction which is going to be given on the uterus, which is going to take the uterus away. Add to that the separation which you are going to do between the bladder and the uterus by incising the UV fold over here and taking the bladder anteriorly. And all of these are going to move the ureteric orifices significantly away from your area of dissection. So effectively, it will be very, very difficult for you to cause an injury close to the ureteric orifices. And hence, in all of this discussion, the idea of doing catheterization, or the idea that we are going to do, we are going to create any damage to the ureter by dissecting a difficult bladder in previous to LSCS, is really, to my mind, not something that makes sense. So much so that I would go on to say that doing extensive retroperitoneal dissection for a case of previous to LSCS really, to my mind, does not make any sense, because the ureters, if you see over here, they are not going to be involved anywhere in the view. Only in cases of large adnexal masses. So like I told you, if there is a large adnexal mass, let's say at this level, something like this, over here. So if there is a large adnexal mass over here, then you find that the ureter is going to course very close to the mass, this yellow structure, or you may also have some adhesions with the mass. In that case, definitely what you will need to do is you will need to dissect out the ureter, and then retroperitoneal dissection might be useful. So if this is stuck in cases of DIE or a large mass, then I can understand that it makes sense. Otherwise, extensive retroperitoneal dissection, to my mind, makes no sense at all. So having understood that, let's go back to the discussion now. So coming back to the discussion, like we said, we have to differentiate between whether we are talking about a bladder injury or a ureteric injury. And for all practical purposes, ureteric injury is not under consideration now. So we are talking only about bladder injury. So what are the issues at hand here? What are the ways in which bladder can be injured during laparoscopic hysterectomy? First is, I would imagine there can be a cut injury to the bladder. Secondly, there can be a thermal injury to the bladder. Other than this, I do not know any other way that the bladder can be injured. So the question of causing a crush injury, etc., is not there. A crush injury may be caused to the ureter other than 1 and 2, which can also be there, but this will probably be in open surgery. So really not our concern over here. So we are looking basically at a cut injury or a thermal injury. Now, if it is a cut injury, here there is a difference. So when we talk about bladder injury, and if there is a cut injury, then in case of a cut injury, a prolonged catheterization. So first of all, how will you diagnose a cut injury? Diagnosis of a cut injury, if when you ask people, they say that the cut injury while doing bladder dissection during TLH will be diagnosed by bleeding, or you will get blood in the catheter or blood in the urine bag. Now most of the times a cut injury may not result in bleeding very often, for the simple reason that we usually do not cut or dissect the bladder in its complete extent using cold scissors. If you are doing that, then it is possible that you make a clean cut injury that may result in bleeding, and then that will give rise to hematuria. However, most of the times we end up using an energy source, like it could be the shearer, or it could be the harmonic, or whatever it is that you use, in which case there will be coagulation, and then you will have cut it. So the possibility of having bleeding is a little less. Then what can happen if you have a cut injury to the bladder? Remember, we are talking only about cut injuries over here. If you have a cut injury to the bladder that you have created after doing some coagulation, then the net result will be that usually you will not get any hematuria. Okay, you will not get hematuria intraoperatively, you will not get hematuria postoperatively. What you will get with a frank cut injury to the bladder done during TLH is you will be able to see air, that means gas, in the urosac bag. The urosac bag will swell up with gas, and you will have a tense, fully distended balloon full of air that you will be able to see, and that can be your earliest marker of having created a cut injury. Now comes the question of whether prolonged catheterization will help in this case or not. So if a cut injury is being made and the cut injury is diagnosed on table, then it is obvious that the injury has to be repaired. We usually repair this in 2 layers, and we do this with 3-0 Vicryl, okay, where the first layer is continuous, watertight, and the second layer can be interrupted and burying. It buries the first layer. So that is understood. If you have done this kind of repair where you have diagnosed the injury, then you have repaired the injury, then the bladder requires some rest. And for this rest, we usually advise prolonged catheterization for a period of, earlier they used to say 14 days. Now people say even 10 days is enough, and some people say even 7 days is enough. So for me, I keep the catheter inside at least for 10 days, provided this sequence of events has been followed. That means a cut injury was made, it was diagnosed on table, it was repaired on table, and then now I want to give the bladder some rest, and therefore I will catheterize the bladder for 10 days. Now come to the other part of the equation where a cut injury was made and it was, sorry about that. So a cut injury was made, but it was not diagnosed on table. If that is the case, cut injury was made, but it was not diagnosed on table, then in that case, and you are suspecting that you have made a cut injury, then in that case, if the injury is very small, maybe a few millimeters in size, then prolonged catheterization might help by giving rest to the bladder and causing the this thing to heal, causing the injury to heal. However, this situation where you have made a cut injury and not diagnosed it on table itself is a difficult proposition, because Either you will see the urosac getting filled up with gas, or if you have made a cut injury directly with a scissor, you will see hematuria. Therefore, in these cases where you suspect that you have made a cut injury, this is the case where I would like to perform a dye test. And if the dye test, by putting methylene blue dye inside the bladder, if this dye test turns out to be positive, then obviously I have found where the injury is, and I will go ahead and repair that injury. Once I have repaired that injury, then again the same sequence of event follows, that in order to give the bladder rest, I am going to give prolonged catheterization for 10 days. So I hope the flowchart is clear up till now. Now we come to the other type of injury, which is the coagulation injury. So I'm going to get rid of all of this, and now we are going to come to the other type of injury, which is the burn injury. So how can you create a burn injury? And this, to my mind, will be the the more significant type of injury. And how could you create a burn injury while doing a hysterectomy? Excessive cauterization. Okay, as has been asked in the question. So this is the actual question for which we are doing the discussion, and the doctor has said that if there is excessive cauterization which has been used. Now, first of all, one point of note is that whenever you are using energy to dissect the bladder, I have been using the laparoscopic bipolar shear for number of years with, touchwood, not a single injury till date. But the idea or the key to using it is to use predominantly or exclusively cutting current only, and to minimize the amount of coagulating current to be used on the bladder. This results in a sharp cut with minimal lateral spread, minimal devascularization of tissue, and a slightly bloody bladder margin will heal off very well. Plus, we must understand the fact that whenever we are doing bladder dissection for LSCS, we are predominantly cutting into the scar tissue. So we are not cutting, if your plane of dissection is correct, then you are predominantly cutting into scar tissue. This is not healthy bladder on which you are applying energy. Therefore, when you are cutting into scar tissue, it is okay to use energy source, and it is okay if you cut it using cutting current, so that the lateral spread will not occur and it will not go and damage normal bladder tissue. So whenever you have done excessive cauterization, so first of all, there should not be excessive cauterization, but if cutting has been done and coagulation, this thing has been done, then you must use cutting current in preference to coagulating current. So coming back to the question at hand, the burn injury, if you have suspected, first ask yourself, have you used only cutting current? If so, and if the dissection was not very difficult, then the probability of you having caused any significant injury is very less. If you have used coagulating current, or even assuming the fact that you have used both of them in a random mixture or in varying combinations, usually devascularizing injury to the bladder heals very well. Okay, and because of the bladder thickness, and because the bladder is very well supplied by blood vessels, it has a good supply of blood vessels. That is the reason that we have always been taught that bladder is a very forgiving organ, and therefore a small devascularization injury where you have used a little more bipolar than what is required is going to heal itself quite well without any problem. So it is not for a small superficial bladder burn that you need to keep the catheter in place for 14 days. What could go wrong is if you have used excessive coagulating current and you have caused a full thickness burn of the bladder. Okay, if you have caused this full thickness burn of the bladder, then there is a problem. What is that problem? So we are talking now about full thickness burn. This full thickness burn of the bladder will not result, you will not get hematuria. This full thickness burn of the bladder is already tissue that has been devascularized and lost. Why we are doing prolonged catheterization? is for the bladder to be rested and to heal when there is a full thickness cut, to the bladder, so that the sutured margins can heal very well. When there is a full thickness burn to the bladder, at that time, whether you catheterize or not, it will not make any difference, because the burnt tissue has already been devascularized and is not going to return just by keeping the catheter inside for a long period of time. So again, I reiterate that a full thickness burn to the bladder is going to be very difficult to do surgically also, unless the surgeon is not very careful in what he is doing. And you can also do judicious surgery, meaning that, let us say that this is the uterus and you are doing surgery. The uterus is like this and the bladder is over here like this. And while dissecting, we usually find that there is one adhesion band over here, and once you have gone beyond the adhesion band, everything else is clear. However, sometimes one finds that the adhesion bands are present at multiple places. So if you feel that you are having to use excessive cauterization between the bladder and the uterus, switch immediately from your energy source to cold scissor. And at the risk of causing bleeding, complete the dissection with the cold scissors itself. This will take some practice to understand when this switch has to be done from energy source to cold scissor, but most of the times, if you are judicious, if your traction is good, which is a very important factor, then even by doing dissection with energy source, you will be able to easily negotiate and dissect the bladder down. So far whatever we have discussed has been that if you have created a cut injury which you have diagnosed on table, then you will suture it, and then prolonged catheterization will be required. If you have created a cut injury, if you have not diagnosed on table, that means you have not sutured it, catheterization may help if the injury is very small, so literally a few millimeters, but this puts it in a questionable zone. Ideally, I say again, this situation should not arise, because any hint of doubt of a cut injury, you must test it by methylene blue dye on table. Then thirdly, we have seen about burn injury, and like I said, burn injury, there is no point of doing a testing with a dye, because the integrity of the bladder is not affected, and therefore your dye test is not going to turn out positive. There is no point of doing prolonged catheterization. So prolonged catheterization is again a no here, because prolonged catheterization will not help. It is not needed in a superficial burn, and it will not help in a deep burn. So in either circumstance, the prolonged catheterization is not going to work if you have created a burn injury. For a cut injury, definitely. Now last point to be discussed is the role of cystoscopy. So again, if you see, cystoscopy will again help to tell you if there is a cut injury, because you will be able to see the cut, you will be able to see bleeding, etc, etc. If it is a burn injury, again, if you have a superficial burn injury, it will not be diagnosed by cystoscopy. If you have a full thickness burn injury, then it will be diagnosed with cystoscopy. So this decision of whether to do cystoscopy or not will depend on the surgeon, and to the extent of his or her estimation as to what type of injury he or she has caused, whether it is cut or burn, and whether that burn is an extensive full thickness burn or a superficial. Most of us, with the injuries we create among all of these, will lie in this category. We are suspecting and we are worried about a superficial burn, not a deep burn, and we are not worried about cut injury, because the cut injury has ideally been diagnosed on table. So to conclude this very long discussion, my advice would be, in the present case which the doctor has presented till now, in this particular case, I will go with the opinion that such cases prolong prophylactic catheterization as prophylaxis. The question is very clear to prevent VVF. I will go with no, it won't help for the reasons that I have given below. So I hope this discussion has been helpful. If you have any difference of opinion in what I have discussed till now, please leave a comment below the YouTube video which I'm going to post now. And if you are part of our discussion group, please leave a comment in on the discussion group. And if you're not yet a part, I would invite you to join by visiting our website endogynetraining.com, where you can also participate in the discussion. So thank you so much for your patience and for listening.